here's all the complications of having a gallstone. And that's why I wanted to put this all into one section for you so that you can understand the similarities and the differences between each of these 6 conditions. So let's draw this pictorially. Biliary colic, the first of the 6 complications we'll go over, is caused by the stone contracting against the cystic duct, and that can cause inflammation. Cholecystitis is when a gallstone gets stuck in your cystic duct. Choledocholithiasis is when the gallstone gets stuck in the common bile duct. Gallstone pancreatitis is when it gets stuck in the main pancreatic duct. Ascending cholangitis is when a gallstone gets stuck in any of these regions, but most commonly the main pancreatic duct or the common bile duct, and it gets stuck and an infection can form proximal to that blockage. And lastly, Gallstone Ileus is when a very, very large gallstone can make it into your GI tract and it gets stuck in your intestine. So let's start with biliary colic, which is when the stone, it's still in the gallbladder, but it contracts against the cystic duct. So just to clarify, colic is where you have severe fluctuating pain. That's when they describe colicky pain. You hear it in a few different conditions, gallstones being one of them. Kidney stones can cause colic. Small bowel obstruction can cause colicky pain, where you have the pain and then it goes away, and then you have the pain and then it goes away. And so why is it causing this colicky pain that comes and goes? Well, what's happening is that each time your gallbladder is contracting, that gallstone can start rubbing against the cystic duct and causing a little inflammation. And then when your gallbladder relaxes, that stone goes away. And then when it contracts, it does the same thing. So that's why you get this severe fluctuating pain in biliary colic. So again, in pictorial format, if we have bile here, let's just say most of the time that bile will flow right out. But if we have a gallstone already formed in our gallbladder, what can happen is that once the gallbladder contracts, it'll push against that cystic duct, cause some inflammation and pain, and then over time it'll relax, and then it'll get contracted again later on. It'll push against that, and so you can see that colicky pain pattern happening right here. So this will present with a few different things. It can present with right upper quadrant pain, with nausea and vomiting. The right upper quadrant pain should make sense to you because we're in the right upper quadrant with the liver and the gallbladder. Postprandial should also make sense. So after meals, you're going to have more pain. And that's because, especially with fatty foods, and that's because when you eat meals and you have fatty foods going to the duodenum, we're going to have our eye cells in our duodenum secreting that cholecystokinin and causing that gallbladder contraction. And once it contracts, you can get that gallstone getting stuck there and causing inflammation. The pain may also radiate to the right shoulder, and we'll see this with a couple other biliary complications. The reason that happens is because right above your liver is your diaphragm, which is innervated by the phrenic nerve. And so that inflammation can actually reach the nearby phrenic nerve and travel all the way up and cause referred pain to the right shoulder. You treat this, like we talked about gallstones initially, even if they're asymptomatic, you can treat cholelithiasis with a cholecystectomy, especially if you have symptoms like biliary colic and you can tolerate the surgery. It's a highly effective intervention. So now let's talk about cholecystitis, and we'll go over some of the differences between the two. So in cholecystitis, you have inflammation of the gallbladder, as the name suggests, and there's a few different subtypes of cholecystitis. The one we've kind of been talking about so far is acute cholecystitis, specifically acute calculous cholecystitis, which just means cholecystitis caused by a calculi or a stone. You can get chronic cholecystitis as well, and you can also have a rare type of cholecystitis called acalculous cholecystitis, which is where you're getting inflammation of the gallbladder unrelated to any gallstone in the way. This is usually caused by really critically ill people who have gallbladder stasis, and that gallbladder stasis can eventually lead to inflammation in that gallbladder. And we'll talk about each of these three subtypes. I first want to start with the gallstone-related subtype. And so the reason why you're getting inflammation of the gallbladder is because you have a stone that's stuck within your cystic duct. So here we have our picture here of bile flowing down and everybody's happy. But in acute calculous cholecystitis, you're going to have a gallstone stuck there. And because there's nothing that can escape, you can easily have inflammation over time. This will present with a fever and leukocytosis, which shouldn't be a surprise to you because whenever you see that itis, I want you to think about that elevated white count and fever in most cases. You'll again have right upper quadrant pain. You'll have right shoulder pain for that same reason we talked about before with biliary colic, and you can have some nausea and vomiting as well. They also like to test on Murphy's sign, which is a physical exam maneuver that we can do. And what that is where you'll have somebody take a deep breath while you're palpating their right upper quadrant, and they'll quit breathing deeply for a moment because of the pain. So let me show you what that looks like. In Murphy's sign, the provider will put their hand in the right upper quadrant below where the gallbladder is. And when you take a deep breath, what's happening is that your lungs are expanding and all your abdominal contents are getting pushed down as that diaphragm moves down. So if that's our diaphragm, everything's starting to get pushed down when you take that deep breath. And part of what's getting moved down is our gallbladder here. And when our gallbladder moves down and makes contact, when this inflamed gallbladder makes contact with your hand, that's going to cause a really severe pain. And so during that deep breath, they're going to basically stop breathing very quickly because of that pain. So how is this diagnosed? Just like you're going to see this very common, where a right upper quadrant ultrasound can diagnose some of these gallstone-related diseases. You might have to use something called a HIDA scan. Let's say you have a very high clinical suspicion. This person meets all the risk factors for gallstones, or they've had a history of gallstones in the past, and they're having the symptoms. They have a positive Murphy sign, fever, leukocytosis. Like you are sure that this is cholecystitis. And then you do the right upper quadrant ultrasound and you can't find any gallstones. Now you're like, what do I do? So if your suspicion is high, you can do something called a HIDA scan. And the classic thing on test that they'll say is that if you fail to visualize the gallbladder on a HIDA scan, that's suggestive of cholecystitis. So what does that mean? So basically in a HIDA scan, what you do is you release all this contrast into the bloodstream. And that some of that will end up getting picked up in the liver. It'll flow through the bile ducts just like bile does, and then that'll get excreted. And so if you saw a HIDA scan for this person, they'd have contrast in all these regions to some extent. If you have a gallstone though in your cystic duct, then that contrast could never make it into the gallbladder in the first place. So when you'd do a HIDA scan here, you would have a failure to visualize the gallbladder in this case. Here's a normal HIDA scan where everything's working well. And I want you to recognize that the gallbladder here is visualizable in each of these. They won't give you a HIDA scan photo, but I just wanted to explain the process. And that's why a failure to visualize the gallbladder is suggestive of acute cholecystitis, because the contrast can't make it in through the cystic duct and into the gallbladder. So you treat this with an urgent cholecystectomy. You want to get this done quickly because before this inflammation gets any worse. And the complications of this, if you have inflammation in your gallbladder, that could always, just like appendicitis had that same risk of rupture. Anytime you have that inflammation in one of your visceral organs like this, you run the risk of rupture. And another complication is chronic cholecystitis. So this is a good segue to talk about chronic cholecystitis. This is, as the name suggests, chronic inflammation of gallbladder, usually due to untreated acute cholecystitis. And this can lead to a calcified gallbladder, also known as a porcelain gallbladder. Here on this X-ray, you can actually see the lining here of your gallbladder, which is unusual. So that's known as the porcelain gallbladder, suggestive of chronic cholecystitis. The complications that can arise from chronic cholecystitis is that you have so much inflammation in this area over time that it can increase your risk of gallbladder cancer. And as you might have guessed, treatment for this is a cholecystectomy. Who would have thought? I'll just briefly mention acalculous cholecystitis. It doesn't really fit in with our whole gallstone pathologies that we've been talking about so far, but acalculous cholecystitis means cholecystitis that forms without any stone. You'll see this in critically ill patients. And what's happening here is that instead of obstruction causing a problem, it's actually just gallbladder stasis. They're so sick, there's no flow from the gallbladder out to the duodenum that you're just going to eventually cause inflammation and ischemia to that region. So here you go, no obstruction, critically ill, you get significant gallbladder stasis, which causes inflammation and ischemia. The one thing they love to test, I don't think I've ever seen a question that hasn't had this specific answer choice. They'll always bring somebody who has, like, they'll say this critically ill person, they have all the symptoms of cholecystitis, there's no stone detected, what's happening? Or they'll say, like, what bug is causing this? And so the very common bug that causes acalculous cholecystitis in critically ill patients is CMV. So do not forget this. CMV is a very common contributor to acalculous cholecystitis. So now let's kind of go back to our gallstone-related pathologies. We just talked about acute cholecystitis. What happens when we have the stone make it to the common bile duct before it gets stuck? So that's choledocholithiasis. As I just mentioned, that's a gallstone in the CBD. So this will present with biliary obstructive symptoms, which we've talked about a lot earlier in this lecture on the physiology section. So this can cause jaundice, elevated alkaline phosphatase or gamma glutamyl transferase, elevated conjugated or direct bilirubin. And remember, it can cause all those other symptoms that we discussed earlier today too, like the dark urine, increased cholesterol, among other things. So remember that the liver creates bile, it's sent to the gallbladder, and when the gallbladder contracts, it flows all the way down into the lumen. In biliary colic, we didn't see any of these biliary obstruction symptoms because even if the stone gets stuck here and you lose this outflow tract, you still have a lot of the bile flowing out and into your GI tract. Same thing with acute cholecystitis. Yeah, we lose this area here, so we can't get this out. But most of the bile that's getting produced by the liver can easily escape out. So you're not going to get obstructive symptoms in biliary colic or acute cholecystitis. The problem that we're going to start running into with choledocholithiasis, as well as gallstone pancreatitis, which is when it's stuck in this region, and ascending cholangitis, when you have something stuck with an infection, you're going to start to see obstructive symptoms because bile cannot escape now, and it'll actually leak out into the bloodstream. So from our physiology section on the gallbladder that we talked about earlier today, you can see that this whole host of biliary obstructive symptoms now can occur as a result of this blockage, because all of that's getting released into our bloodstream now. So the complications of having a stone in your bile duct, in addition to that obstructive symptoms, choledocholithiasis can eventually cause gallstone pancreatitis if it keeps moving down to block the main pancreatic duct, or it can cause ascending cholangitis if that stone stays long enough for a bacterial infection to start to brew proximal to that obstruction. So let's talk about these two complications. So gallstone pancreatitis is when the stone makes it all the way down where it lodges in the main pancreatic duct / the CBD here. So in gallstone pancreatitis, we know where the stone is. This prevents outflow of pancreatic fluid. And when you have blocked outflow of pancreatic fluid, that can actually lead to acute pancreatitis. So again, if the stone makes it all the way down here, you're going to have most of the time our pancreatic enzymes are free flowing and they're trying to escape into the lumen. But if they get stuck there, then you can have trypsin be prematurely activated within our pancreatic ducts, and that can cause inflammation or acute pancreatitis. And when we talked about acute pancreatitis in our pancreas lecture, I mentioned that gallstones are very, very common contributors where a gallstone blocks the duct, it's activated, and you have inflammation. And even here, you can see that the most common cause of acute pancreatitis is gallstones in the first place. 40 to 70% of gallstones, depending on which resource you use, 40 to 70% of all cases of acute pancreatitis are caused by gallstones. So very common. How does this present? The presentation is pretty obvious. It's going to be pancreatitis, but it'll also be biliary obstructive symptoms. And that should give you an idea. Whenever you see somebody with the classic pancreatitis picture, epigastric pain radiating to the back, super high lipase levels, and characteristic imaging findings, depending on, you just need 2 out of those 3 for the diagnosis. Whenever you get the diagnosis of pancreatitis, the first thing I want you to do is think about why they're having pancreatitis. Is it alcohol related? Is it triglyceridemia? Is it hypercalcemia? Is it gallstone, alcohol, scorpion bite, mumps? There's so many, ERCP, there's so many different causes. And so on a test, once you see somebody with classic pancreatitis signs, oftentimes the first thing you'll do is order a right upper quadrant ultrasound to see if gallstones are the problem. Or sometimes they'll give you liver function tests, and if those show elevated conjugated bilirubin, elevated alk phos, that should give you an idea, or elevated GGT levels, that should give you an idea that, okay, it's probably going to be caused by a gallstone because you're having obstructive symptoms and pancreatitis. So again, not only in this case, if there is a gallstone lodged here, not only are your pancreatic enzymes obstructed, but your bile is obstructed too. So you'll get the same problems that we've talked about before. I'm going to go back. You get the same problems that you talked about before with an obstructive pattern. Ascending cholangitis is a little different, and this is actually more dangerous. This is a life-threatening infection of your biliary tree with almost a 10% mortality rate on some resources. So what's happening here is that the stone is blocking either the common bile duct or it makes it down further. But the important thing with ascending cholangitis, as the name suggests with the itis, is that you're having a bacteria ascend through the tree and causing an infection or inflammation. So because the bacteria is ascending from your GI tract, you're going to commonly get your gut flora like E. coli, Klebsiella, and Enterobacter. Those are usually the culprits of ascending cholangitis. So normally, if you have bacteria in your GI tract, if they so happen to find a way into your biliary tree on accident, your bile can just wash them back down into your gut, and there's no problem with that because that's where they belong usually. However, if there's a stone blocking it, sometimes these bacteria can kind of sneak around that stone and get into here, and now there's nothing to really wash the bacteria away. And now they're in a spot where they can cause serious damage. So there's a triad and a pentad that you have to know with ascending cholangitis. So first one I want you to realize is the Charcot's triad, which is fever, jaundice, and right upper quadrant pain. And the fever and right upper quadrant pain should make sense. We've actually seen this we saw this in acute cholecystitis, right? We saw that inflammation can cause right upper quadrant pain and fever. But the difference with ascending cholangitis is that because it is in the common bile duct, it should also cause obstructive symptoms like jaundice. So here again, if you have bile leaking out into your bloodstream now, you're going to get all these biliary obstructive symptoms are possible in ascending cholangitis, in addition to that fever and right upper quadrant pain. Now, in severe cases of ascending cholangitis, they're going to develop Raynaud's pentad, which basically just means they're in shock. Like they're so sick now that their body's going into shock. So you're going to see all those 3 symptoms that we talked about. So you're still going to see Charcot's triad. You're going to start to see altered mentation, and you're going to see hypotension. So basically, this person's hypoperfusing now. They're going into shock, and that's why you get this Raynaud's pentad. On laboratory evaluation, you're going to get an elevated white count, which again shouldn't surprise you. You're going to get obstructive labs like elevated alk phos, elevated C-Bili, elevated GGT. And again, that shouldn't surprise you because we, in our biliary obstruction symptoms, we have those as part of this subset of symptoms. And that's all you need to know for ascending cholangitis. I think oh yeah, sorry about that. That's all I had for ascending cholangitis. Now let's talk about Gallstone Ileus, which is kind of its own category of things. So how does it make it into the GI tract? What actually happens here is it doesn't take the same route that the other gallstones have been taking. Instead, you're going to have this huge gallstone that can't even make it into the cystic duct, and it's just going to be pressing against the wall of your gallbladder. And that pressure over a significant amount of time will slowly erode away the gallbladder wall. And eventually there's going to be a fistula that can form between your gallbladder and your duodenum directly. And once that happens over time, that gallstone can actually sneak into your small intestine, and it'll travel all throughout your small intestine, and your ileocecal valve is the smallest point of your intestine. So it'll travel all the way down, and it usually gets stuck right at that ileocecal valve in the right lower quadrant. So again, if we have this huge gallstone, normally gallstones would be able to flow out this outflow tract when the gallbladder contracts, but this gallstone's just too big to even fit through the cystic duct. So it's just going to sit in your gallbladder, and over time, it's going to cause pressure necrosis of that wall. That once that necrosis has gone, then a fistula can actually form between the gallbladder and the small intestine, and that gallbladder can enter the small intestine. And like I said, that gallstone will now travel down the small intestine until it reaches the ileocecal junction at the right lower quadrant. So you could see it here. Gallstone forms, it moves along the small intestine and makes it to the ileocecal junction before it gets stopped. And so imaging findings, they could mention that they find something in the right lower quadrant, or you palpate something in the right lower quadrant, but more often than not, they like to test you on the concept of pneumobilia. So pneumobilia is air in the biliary tree, and that's unusual. So normally we have air in you can have air in your GI tract, that's fine. But if the air ever tries to get into your biliary tree, we have our sphincter of Oddi and a few other things that seal this area off, and that you don't allow significant amounts of air inside your biliary tree. In Gallstone Ileus, though, you form this fistula between your gallbladder and your GI tract, and so that air can actually start moving into that region, and you'll find air in your biliary tree on imaging studies. And like I said, you might actually see a gallstone in the iliac fossa. I've yet to see a practice question or a test question that shows an image of this, but they sometimes will mention that. I've seen them verbally mention that you have something in your, right lower quadrant. And because you have this massive gallstone that's kind of obstructing the ileocecal valve, then you could obviously get small bowel obstruction in some cases. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.